Next slide. So we're hosting this session on the unceded and ancestral territory of the Coast Salish peoples. That includes the territories of the Musqueam, the Squamish, and the Tsleil-Waututh nations, and the Métis charter community of the Lower Mainland region. And you around this province and other places on Turtle Island are obviously on your territories. I think we've learned certainly this week of the land and how it changed people's lives quite quickly. And so with that, we really respect where we are, who we are, and vow to take care of it, perhaps a little bit better than we have in the past. Next slide. So we have the privilege of having Dr. Matt James speak with us today. Matt is an associate professor at the Division of Nephrology and Medicine in the Department of Community Health Sciences at the Institute and the Libin Cardiovascular Institute of Alberta at the University of Calgary. I think for us, it's great to reflect that he actually got his initial training in medicine at the University of British Columbia, and then his nephrology and PhD training in epidemiology at the University of Calgary. He's co-lead of the Alberta Kidney Disease Network and the Interdisciplinary Chronic Disease Collaboration, ICDC, and the Director of Research of the Alberta Provincial Project for Outcomes Assessment for Coronary Disease Approach. He's also the project lead on CanSolve CKD network program, looking at cardiovascular disease, and he's been really dedicated to helping both clinicians and patients understand better cardiovascular disease and kidney disease. And with that, I'll stop talking and hand it over to you, Matt, and thank you very much for your thoughtfulness and making the time. We'll come back.
Thanks very much for having me. Just bear with me one moment while I make sure I can get my screen sharing working.
Just go into slide mode. Yeah, there you go. Perfect.
Great. Thanks. Yeah, thank you very much. Thanks for the opportunity to speak with you today. I am going to be speaking about cardiac outcomes in chronic kidney disease, and particularly focusing on coronary heart disease. I would just like to disclose some of my grant funding up front from CIHR and Alberta Innovates, also the support through the CanSolve CKD network, and I also have some funding from Amgen Canada related to acute kidney injury research. What I'd like to cover in the hour today is really three objectives. The first is to appreciate the risks of cardiovascular events and how they vary across the spectrum of chronic kidney disease, again, focusing largely on coronary heart disease today. I'll spend some time reviewing the effectiveness of medical interventions in a few areas of primary and secondary prevention of coronary disease in CKD populations. And then the third objective will be to explore some of the recent evidence around the impact of invasive management approaches for coronary heart disease in patients with CKD, and try to end on some discussion of how we can apply it in our patients. So I'm going to start with these two figures to set the stage. These are from several years ago now, but speak to the risk of cardiovascular events and poor outcomes after cardiovascular events of people with chronic kidney disease. The figure on the left from a study in the United States shows the increase in risk of having a cardiovascular event as kidney function declines. So on the left, from about an incidence of 2 events per 100 person years in people with preserved kidney function, a GFR above 60, all the way up to almost 40 events per 100 patient years for patients with kidney failure or an eGFR less than 15 here. The figure on the right is actually from an American cohort of patients who were hospitalized with a myocardial infarction, and actually shows a number of adverse outcomes, and shows that as you stratify patients with lower levels of GFR, you can see that all of these outcomes become worse in patients with lower level of kidney function, including death from a cardiovascular cause, reinfarction, hospitalization for heart failure, stroke, or resuscitation. So kidney disease carries a risk of both experiencing a cardiovascular event and having a poor outcome following one. And this is a figure of the CKD Prognosis Consortium. So There are really meta-analyses of many cohorts of patients that are characterized based on eGFR, left, and albumin ratio. And what it's showing on the left is that as GFR declines, there's an increasing risk of cardiovascular mortality, both in people with and without diabetes, but even higher in people with diabetes and low GFR. And as albuminuria increases, we know that there's increasing cardiovascular mortality as well in a linear manner. This figure summarizes some research we've done in Alberta, looking at the risk of death and myocardial infarction in people with kidney disease and other comorbidities. So what the figure shows on the left here is gray bars representing people who've had a prior myocardial infarction. So a group that we recognize is at extremely high risk of having another cardiovascular event. And we've often thought, that patients who have risks that are equivalent to this have what we would call a coronary disease equivalent because they have similar risks of having another cardiovascular event. What the green bar represents is patients with diabetes and chronic kidney disease. The red bars are people with just chronic kidney disease, blue is people with just diabetes, and purple is people with neither condition. And what the figure is trying to show is that people with diabetes and chronic kidney disease actually have a risk of myocardial infarction that's almost as high as people who've had a myocardial infarction. So this concept of having a coronary artery disease equivalent. In the lower panel of the figure, you can see that if we just look at all-cause mortality, the risk in this population with diabetes or CKD without diabetes is even higher than people who've had a recent MI. And this is a figure that was produced by Mark Sarnak from a recent KDIGO conference that I think really nicely illustrates the increasing risk of cardiac and coronary events in people with chronic kidney disease as disease progresses, moving from left to right, and also shows how the poorer prognosis is seen with lower levels of kidney function moving from left to right. And it does a nice job, I think, of linking the epidemiology and some of the pathophysiological processes together. And what the yellow part of this figure is trying to show is that as patients develop chronic kidney disease, there's this rapid increase in risk of atherosclerotic cardiovascular events in particular, including atherosclerotic coronary disease, ischemic stroke, and peripheral vascular disease. But as we move even further into lower levels of kidney function, we see this growing sort of purple color in the top where many other non-atherosclerotic factors start to grow as well in their prevalence. So we see more contributions from the non-atherosclerotic cardiovascular diseases. We see the growth of left ventricular hypertrophy, more prevalence of arrhythmias and sudden cardiac death, the arterial calcification that affects arteries and also valves, and then hemorrhagic stroke. So many other cardiovascular risks start to accumulate. And then the bottom part of the figure is just really showing that mortality and risk of dying after all of these events grows as kidney function declines. I wanted to spend just a little bit of time on this study because it speaks to how patients with chronic kidney disease often present differently with coronary disease. So this was a case control study done in the United States that actually looked at the first presentation of patients with coronary heart disease. And it actually looked at these risks across different levels of eGFR, moving down this table from top to bottom, and then fit a number of models actually to try to look at what the first presentation was. And was this actually an acute coronary event, or was it a presentation with stable coronary artery disease? And what you can see across all the models is actually with chronic kidney disease, particularly when GFR was below 45, the odds of first presenting with an acute coronary syndrome actually increase. So it's actually around a 2 to 3-fold increased odds of having your first presentation with an acute coronary syndrome. And this probably speaks to some of the factors that coronary artery disease can often be relatively asymptomatic in patients with chronic kidney disease. This may be because they experience less chest pain due to other comorbidities, including diabetes and kidney disease. It may be because they are exerting themselves less, and so don't necessarily develop the same degree of anginal symptoms with exertion. But I think it's important to recognize the difference in this presentation, the high risk of presenting with acute coronary syndrome, and then the need to have some degree of suspicion of coronary disease even in patients without symptoms. And this slide is really just to highlight that the issue of heart disease is important to patients with chronic kidney disease. This was a priority setting exercise done just prior to the initiation of the CanSolve CKD network that looked at the top research priorities from the perspective of patients and caregivers in both patients who had chronic kidney disease not requiring dialysis and patients who had chronic kidney disease on or nearing the need for dialysis. And in both groups, questions around how to improve heart health and cardiovascular outcomes and the best approaches to prevention and treatment of these problems were within the top 10 research priorities for people with chronic kidney disease. I'm going to move a little bit now into some of the medical therapies and interventions and the evidence behind them in patients with chronic kidney disease. And in the interest of time, I'm skipping over a lot of older literature related to ACE inhibitors and angiotensin receptor blockers, and I'm going to sort of jump in at the literature on hyperlipidemia. And I wanted to start with this slide. This was work out of Alberta as well, where led by Cello Tonelli, where he looked at LDL concentrations in patients in Alberta and looked at the risk or the hazard ratio here of having a myocardial infarction. So what the figure shows is a number of panels that are stratified by the eGFR of patients. So we have from the model patients with a GFR of 15 or lower, those with a GFR of 30, 45, 60, and this panel in the middle on the bottom of patients with preserved kidney function with a GFR of 90. And the point here to observe is how these curves showing this relationship between LDL cholesterol and the risk of myocardial infarction start to flatten quite substantially as you go down into lower levels of eGFR. So actually the strength of this association between increasing LDL concentrations and myocardial infarction actually starts to become attenuated with lower and lower levels of kidney function. And this probably again speaks to the differing pathophysiology of coronary disease with progressive chronic kidney disease. This is the slide to remind ourselves of the SHARP study, a large randomized controlled trial of lipid lowering in patients with chronic kidney disease that included both patients with chronic kidney disease as well as those with end-stage kidney disease on dialysis. This was a randomized controlled trial that compared simvastatin at 20 milligrams a day plus ezetimibe versus placebo, and looked at a primary outcome of atherosclerotic cardiovascular events, including coronary death, myocardial infarction, revascularization, and ischemic stroke. And what the SHARP trial showed, of course, was that there was a 17% relative risk reduction with lipid lowering therapy compared to placebo over a follow-up of 5 years. This is the figure that shows the results stratified by the stage of kidney disease that patients had. And Dira reminded me recently, this was at the beginning of the trial. So the majority of patients in the trial actually had, are shown in the first few rows here, actually had chronic kidney disease and were not receiving dialysis. And we can see that there was a fairly consistent effect of the intervention across different levels of GFR and albumin to creatinine ratio. The lower rows show the effect in patients on hemodialysis and peritoneal dialysis at the start of the trial. And you can see, just looking at the point estimates, that there appears to be, at least visually, an attenuation of the treatment effect in the patients who were on dialysis at the beginning of the trial. When this was formally tested in the SHARP trial, there was actually no statistical evidence of effect modification by dialysis versus non-dialysis chronic kidney disease status, although certainly, visually it appears that there's some attenuation in the effect going on. This is a large meta-analysis that actually took the literature on statin therapy in patients with chronic kidney disease and synthesized it back in 2012. And I think it helps to point out some of these differences in effects seen in many trials that were done in dialysis populations versus trials which were done in CKD and transplant. So the way this is presented here is by outcome. So we have all-cause mortality at the top, cardiovascular mortality, major cardiovascular events, and then fatal or non-fatal myocardial infarction. And then we see the trial results stratified by whether the populations were CKD not receiving dialysis, or transplant. And what's quite apparent is that the effect of lipid lowering seems to be most strong in the trials that included patients with CKD not receiving dialysis. So we see quite a consistent effect of a benefit of treatment in the population of patients with CKD not on dialysis. All of the point estimates in the dialysis population are significantly attenuated compared to that and approach the null effect across all of these outcomes. And then more variable findings in the transplant population where there are much fewer trials to inform the evidence. But in these analyses, you can see here in the right-hand column that most of the variance across these trials is actually explained by the stage of chronic kidney disease. So between 90 to 100% of the variance between trials can actually be accounted for by whether really this is a dialysis population or a pre-dialysis chronic kidney disease population. So really emphasizing that probably lipid lowering therapies have diminishing benefits with progression of kidney disease. Where that benefit really starts to change is a little more challenging to say from these trials. It's probably not at one moment in time when patients transition to dialysis therapies, but certainly as kidney disease progresses to that stage, the benefits are substantially attenuated. I'm going to move on to SGLT2 inhibition, which I'm sure this audience is very aware of, but I wanted to spend some time on it just to look more specifically at the cardiovascular outcomes with these interventions in patients with chronic kidney disease. I'll start with the Credence trial here, which was a trial of canagliflozin, 100 milligrams a day versus placebo in patients with type 2 diabetes who had a GFR between 30 to less than 90 mils per minute, or albuminuria between 30 to 500 milligrams per millimole. And all were already being treated with renin-angiotensin system blockade when they entered this trial, and they were followed for a median of 2.5 years. And this is the figure for the primary outcome, which was largely a renal outcome of doubling of creatinine, end-stage kidney disease, renal death, or cardiovascular death. But just to focus on the cardiovascular endpoints, these were also secondary outcomes of the trial. So those secondary outcomes included cardiovascular death or hospitalization for heart failure, cardiovascular death, myocardial infarction or stroke, hospitalization for heart failure, and then a composition of cardiovascular death, MI, stroke, hospitalization for heart failure, or unstable angina. And actually across all of these outcomes, there's about a 20 to 40% reduction in the hazards of these cardiovascular endpoints, showing that, or just a reminder for us that actually these are not just medications that slow progression of chronic kidney disease, but also have significant cardiovascular benefits. I focus a little bit here on the DAPA-CKD trial just to look further into the evidence that this may apply outside of only patients with diabetes, as well as to patients with chronic kidney disease from causes other than diabetes. This trial was focused on a population of patients with CKD, of which 68% did have diabetes, but a number of patients in the trial also did not have diabetes. The GFR was between 25 to 75 mils per minute. They had albuminuria as well, and were also being treated with renin-angiotensin system blockade. This trial again showed a benefit on the primary composite outcome that included kidney endpoints, but also included some secondary cardiovascular endpoints with a composite of death from cardiovascular causes, of hospitalization for heart failure, and death from any cause. And again, showed a reduction of around 30% in the the hazards of this outcome with treatment. And we have seen some subsequent publications from this trial focused on the subset of patients with IgA nephropathy, showing that, in patients with IgA nephropathy and not diabetes, there's still a benefit on the renal endpoints. And we've also seen in other trials of SGLT2 inhibitors in patients with diabetes, as well as in patients with heart failure, that there is a reduction in cardiovascular endpoints. So it looks like this can demonstrate the benefits of these therapies that extend beyond glucose lowering, because we know there's a number of interesting hemodynamic effects of these trials that seem to have important effects on renal and cardiovascular endpoints. And this is a recent systematic review that I think does a nice job of summarizing the absolute risk reductions with SGLT2 inhibitors, including in patients with chronic kidney disease, as part of a large network meta-analysis, but I'm just going to focus on the SGLT2 inhibitor component. So one of the tables actually does a really nice job of showing the absolute risk reductions over treatment periods of 5 years. And it's actually stratified by baseline risk status of patients. But the way this was done is at a trial level, essentially any patients with chronic kidney disease would actually be, or trials that included patients, populations of chronic kidney disease would actually be in the high risk category here. So what these absolute risk estimates show us is that with treatment of 1,000 patients for 5 years, these agents can prevent 34 deaths, 16 fewer cardiovascular deaths, 14 fewer non-fatal myocardial infarctions, as well as kidney failure. And the strata here of trials with very high risk are actually defined by patients with chronic kidney disease and established cardiovascular disease. So in this population of our patients who already have both conditions, we see even higher absolute risk reductions with these therapies. I just wanted to end the section on medical therapies, speaking a little more broadly about multifactorial lifestyle interventions and risk factor interventions. So there is a thinking a little bit more broadly just around individual medications, but multifaceted strategies that address lifestyle and risk factors for cardiovascular risk reduction. This was some work that we did in Alberta to look at the use of structured cardiac rehabilitation programs in patients with chronic kidney disease. And what this figure shows, we've got the patients here, about 24,000 patients in Alberta who had angiographically proven coronary artery disease. And we identified those people who had chronic kidney disease identified by reduced EGFR. And the patients in blue are those with CKD, and the patients without CKD are those in orange. And you can see a challenge for these types of programs is that there's attrition of patients, through the stages of being referred to the programs after a cardiovascular event, to actually starting them, and then to completing them. But this attrition is even greater in our patients with chronic kidney disease than without. These patients were older and had more comorbidities, so had more barriers, I think, to participating in these programs. But these types of programs have been evaluated in the general population in well-done randomized controlled trials and have shown benefits on reducing cardiovascular mortality and cardiovascular events. And I think, importantly, when we looked at these outcomes in people with CKD and those without, we saw no difference between those two groups. So our patients with CKD appeared to have the potential to benefit to similar extents than patients without chronic kidney disease. So I'll summarize this section on some of the medical therapies, and I haven't touched on all of them, but I've tried to highlight a few that I think are increasingly relevant today. And I put up this slide just to sort of summarize, how things are now changing after 20 years at least, going back to 2001 when those landmark trials of ACE inhibitors and angiotensin receptors blockers came out in patients with kidney disease, showing the reduction in cardiorenal outcomes, to around 2011 when we saw all the lipid trials and the SHARP trial demonstrate the benefits of statin therapy across different stages of chronic kidney disease. Now, most recently with more newer agents, and I haven't spoken about all the newer oral hypoglycemic and diabetes agents, but certainly with SGLT2 inhibitors in chronic kidney disease, really a strong evidence being developed. And then perhaps now, we're just seeing this on the cusp of increasing evidence related to the role of non-steroidal mineralocorticoid receptor antagonists. So perhaps if we can figure out how to use these safely, we'll have even more therapeutic options in the future. I'm going to shift now the rest of the talk to focus on the invasive management strategies of coronary heart disease in patients with chronic kidney disease. And I'm going to start actually discussing the ischemia chronic kidney disease trial, and also try to place some of its findings in context with the sister ischemia trial that was done in patients without advanced chronic kidney disease. So the ischemia CKD trial was a trial done specifically in patients with chronic kidney disease, which is really neat because, so often we've had trials in cardiovascular disease and interventions that have just excluded people with kidney disease, but here they actually designed a trial specifically to address our patient population. So this was patients with CKD, either an eGFR less than 30 and not on dialysis, or patients with end-stage kidney disease receiving dialysis. This was a population with stable coronary heart disease, so it would exclude patients with an acute coronary syndrome, and all patients in this trial had moderate or severe ischemia on stress testing. So that's how these patients for this trial were identified. So this was largely stress echocardiography or myocardial perfusion imaging, were the two non-invasive tests used to identify ischemia. The intervention was randomization to an initial invasive strategy, which would involve patients proceeding to coronary angiography plus revascularization, either percutaneously or surgery, depending on what was felt to be the appropriate option, or no revascularization if not possible, versus the other arm was an initial conservative strategy where medical therapy would be the intervention, but patients could ultimately end up receiving invasive therapy if they were unsuccessful or failed medical therapy. And I should emphasize that, optimal medical therapy was provided in both arms. And this trial followed patients up for a median of 2.2 years, so a little bit shorter than some of the other trials in this field. These are the baseline characteristics of the ischemia CKD trial. Patients who are about 63 years of age on average, many more men than women, as is often seen here. About 10% of patients, or just over 10% of patients, were actually on the waiting list for kidney transplant at the time of entering the trial. About half of patients were on dialysis, and the majority of them were on hemodialysis. And then the rest of the patients, about the other half, had chronic kidney disease not on dialysis with a median GFR of 23 mils per minute. As mentioned, all of these patients had moderate or severe ischemia on a non-invasive testing. Of relevance, actually their health status based on the Seattle Angina Questionnaire was actually quite high, was actually quite good. So their median summary score of the Seattle Angina Questionnaire was 78 to 79. So this scoring, this instrument actually measures angina on a 0 to 100 point scale, where 100 would be patients having the most severe anginal symptoms, like essentially daily angina, and patients that are, sorry, 100 actually is actually the best health status. So they're actually feeling the best, having the least angina, and patients at 0 actually have the most angina or the worst symptoms. So these patients actually have fairly good health status, at least based on angina. When you look at the distribution of anginal symptoms in the study, about half of patients actually were not having angina. Again, speaking to how patients with CKD often present a little bit differently with their coronary disease. So half of them had really had no anginal symptoms, most of the rest had, mild, what would be called monthly angina, and then about 12% had what would be considered, moderate to severe angina with daily or weekly angina. This is the primary outcome of the ischemia CKD trial on the left, which was death from any cause or a myocardial infarction. And the curves show very clearly that there was no difference in this outcome between patients who had an invasive versus a conservative management strategy. And results were similar with a secondary outcome that's shown on the right, which also included hospitalization for unstable angina, heart failure, or cardiac arrest in the outcome as well. So how did this compare to the sister trial? As I mentioned, there was a larger ischemia trial that included patients with normal kidney function or only mildly reduced GFR, which was much larger. But actually, this, in terms of the main clinical outcomes, the findings were the same. There was no improvement in the major risk of adverse cardiovascular events with invasive management in the population of people with preserved kidney function either. But what was concerning in the ischemia CKD trial, just coming back to the CKD scenario, was actually this safety outcome, that there was actually a significantly increased risk of death from any cause or initiation of dialysis, so largely being driven by more patients needing to start dialysis in the arm of the trial that received invasive management. The trial also has reported outcomes for that 10% of patients who were on the kidney transplant waiting list. So this was about 194 participants who were on the kidney transplant wait list at the beginning of the trial. And actually the findings in this group, which is of obvious interest to our population, is that, again, there was no difference between the two arms in their outcomes, whether they received invasive or conservative management. What was a nice element of both the ischemia and ischemia CKD trials is they included sub-studies to evaluate health status or health-related quality of life outcomes with these interventions. So I will spend a little bit of time summarizing that information from the ischemia CKD trial. The figure on the left shows that Seattle Angina Questionnaire Summary Score. The blue lines show the conservative managed group, and the red lines show the invasive management group. And what the figure shows is that following randomization in the intervention, at about the 3-month mark, both groups had actually shown an improvement in their angina symptoms, but there was no difference between the two treatment groups over the course of the trial. On the right-hand side, we see a different health-related quality of life instrument. This is the Rose Dyspnea Scale. This is measuring dyspnea. So here, actually, being more short of breath or being worse off is at the top of the higher score. Moving towards 0 is having no dyspnea. So here again, we see in both groups with medical or invasive management, there's some improvement in their symptoms, but again, no difference between the two groups in their symptoms over the course of the trial. This figure is from the ischemia CKD trial, and it actually does something very important. It stratifies these results in different columns here based on the amount of anginal symptoms patients were having at the start of the trial. So in the first column, we have the effect on angina overall, all patients in the trial. In the second column here, we have results for those who were experiencing daily or weekly angina, so quite severe angina. And then we had people who had moderate monthly angina and patients with no angina at baseline, who are again half of the patients in the trial. And what these curves are actually showing is the distribution of the treatment effect on the Seattle Angina Summary Score. So as these curves move to the right, we're actually seeing improvements in anginal symptoms with intervention, with invasive management, as opposed to medical or conservative therapy. So what we can see then as we go down these rows, we're actually looking at different time points. So from 3 months, 1 year, and 36 months into the trial. So what you can see is in a smaller group of patients in the trial who actually had daily or weekly angina at baseline, there was a significant, what would be considered a clinically important improvement in anginal symptoms of about 10 points on the SAC instrument at the 3-month mark. But what's important to recognize is actually this benefit was not sustained in the CKD population by 1 year and beyond. Actually, even by 6 months, this benefit had been lost and there was no difference anymore between these treatment groups. In the other groups with less or no angina, it's not as surprising that there was no benefit on their anginal symptoms with intervention. So there may be a role for very symptomatic patients, but it's important to recognize that those benefits do not appear to be sustained in our patients with CKD, which may relate to the rapidity with which coronary disease can progress in patients with kidney disease. And this figure is just to contrast these findings with the larger sister ischemia trial, where at 3 months, again, they found overall there was a benefit in symptoms at the 3-month mark. And this was seen overall, but it was again particularly driven by the patients who were symptomatic at baseline, which was a larger proportion of patients in the overall ischemia trial. And this actually is sustained. It does attenuate over time, but these benefits are sustained beyond 1 year in the non-CKD ischemia trial. So there do seem to be some important differences in the longevity of any benefits seen in symptoms with patients with chronic kidney disease with invasive therapies. I'm just going to highlight the CARSC trial, but you know, in BC, you have leaders involved obviously in this trial, but this is an important trial that is being done in Canada and Australia to evaluate 2 strategies for screening kidney transplant patients for coronary artery disease once they're placed on the kidney transplant wait list. So it's including patients who've already been activated on a kidney transplant wait list, so may have already undergone some evaluation for coronary disease, but essentially the important point is they are on the wait list. And then they're randomized to 2 strategies for screening. So one where routine screening for coronary artery disease is done either every year for patients with diabetes or known coronary disease, or every 24 months for patients without, versus a no regular screening intervention. And this trial is going to look at the risk of major adverse cardiovascular events for patients while they're on the transplant list or in that first year after transplant, which will hopefully resolve this question of how much screening and potential intervention should be done in these patients as they wait on the wait list, as we really obviously want our patients to get to transplant, which is probably their best cardiovascular therapy, but we don't want to introduce unnecessarily harms. I'm going to turn now to acute coronary syndromes, because I think the literature it's important to recognize that the literature is a bit different here than in the stable coronary artery disease, both in people with and without chronic kidney disease. So these trials of invasive or early invasive management really is what they are in acute coronary syndromes were done several years ago now, more than 10 to even 15 years ago now. And this is a systematic review that actually summarizes the treatment effects of early angiography in patients with chronic kidney disease and acute coronary syndrome. So many patients with kidney failure were excluded from these trials, but all these trials had varying levels of creatinine cutoffs. So actually quite a few patients with chronic kidney disease of different levels are included in these trials. Most of them have GFRs between 30 to 60 mils per minute, but there is even a substantial number of patients with GFR below 30 that were included in the ACS trials several years ago. So this systematic review focuses on, these are patients with chronic kidney disease, not on dialysis, who have unstable angina or non-ST elevation myocardial infarctions. And these are trials that randomize patients to an early invasive strategy. This is usually taking patients to coronary angiography within 48 hours of their presentation and revascularizing them again percutaneously or surgically if possible, versus conservative strategies where medical therapy would be attempted, and then patients could proceed to invasive management if they failed medical therapy, which could occur because of recurrence of symptoms or further events, or even in some trials because of very high risk findings on non-invasive testing. And this figure shows two forest plots from this systematic review, one for the outcome of all-cause mortality and one for the outcome of readmission for myocardial infarction. And there's 5 trials that actually have data on kidney function to actually summarize this. And the pooled estimates of the treatment effects actually show reductions in death and myocardial infarction of about 20%, which are consistent with the effects seen in high-risk populations with acute coronary syndromes, which in the general population are the group that benefit from the early invasive approach as opposed to the conservative approach. And I think there's an argument to be made that, you know, CKD patients are high-risk patients too. We looked at this in Alberta in an observational manner with more recent data than when these trials were conducted. So this was a propensity score matched study where we looked at patients with acute coronary syndromes and characterized them according to their kidney disease and compared outcomes with invasive versus conservative management approaches. And this figure is actually showing 3 outcomes. So acute kidney injury at the top, in the middle, end-stage kidney disease, and at the bottom, all-cause mortality, stratified by different levels of kidney function. And what we found is actually the treatment effects of invasive management on these outcomes were not clearly different across different stages of chronic kidney disease. There was an increase in risk of acute kidney injury, a relative risk of about 20% seen across all the stages of kidney disease. With lower GFR, that absolute risk does increase. We had a lack of precision on estimates of the risk of end-stage kidney disease, but we did see lower risk of death in this propensity-matched observational study, which attempts to control for treatment selection bias, but is an observational study still, suggesting that though that some of the effects on survival could be in the modern era with invasive management consistent with what we see in high-risk populations from other clinical trials, as well as the earlier clinical trials in chronic kidney disease. So I'm going to end now really with speaking about some of the work we're doing with the CanSolve CKD network, which is really trying to figure out how we can synthesize and provide this information to our patients and to ourselves, our physicians, both nephrologists and cardiologists, to help navigate these decisions in our patients when there's clear trade-offs in our patient population. So one of the ways we've been doing this is through something called a discrete choice experiment, which is where we use utility theory to try to understand what are the most important attributes of treatment decisions for patients. And we can actually use statistical methods to quantify and measure that. So what we do is we present patients with kidney disease with a number of different scenarios and choice tasks that have different values or attributes for these treatment decisions. And we focus on some of the outcomes that our earlier qualitative work suggests are most important to patients and healthcare providers. And then we use statistical methods to weight these results, and we can then identify what are the most important attributes for patients, and depending on the risk of those attributes, what would be the preferences patients would make when faced with these decisions. And this can be helpful to inform clinical guidelines because they can help us understand how preference sensitive conditions are. And I think they've also been very helpful for us actually just to better understand the preferences of patients and how we can develop strategies to try to understand them and communicate these between patients and healthcare providers. So in our discrete choice experiment here, this figure that I'm starting with here summarizes in the different colors the weighting of which outcomes were most important to patients across these different scenarios. So not surprisingly, the green bar shows that survival overall was the most important outcome for our patients, followed by their risk of end-stage kidney disease and the risk of having another myocardial infarction following. Patients actually didn't mind accepting either an invasive or a conservative treatment strategy, so that the actual procedure itself was not as important to most of the patients as finding the outcome that, or the approach that maximized their outcome to the greater extent. However, we use something called a latent class analysis to tease out the question of whether this is uniform or whether there are different preference groups. And actually, we found that it looks like there are two different groups really occurring. That the main group, group 1 here, is about 80% of patients, and they really mirror that overall group across the entire study. But there is another study population that has different preferences and weights these attributes differently. So they put a much higher emphasis on avoiding end-stage kidney disease and acute kidney complications like dialysis, and actually are more procedure averse. This group has very different goals of care, and it's even reflected in some of their goals of care and resuscitation status as well. So they are much more conservative in their approach, and I think this is important to recognize. What we're trying to do now is really synthesize a lot of this information into tools and models that can inform decision making. So I'll just end a little bit of information of how we've tried to do that. We've been working to develop models that can personalize this information by taking a number of predictors that are relevant to patients with kidney disease, not only their comorbidities, but also measures of GFR, albuminuria, and other factors. We then develop models that can produce individualized absolute estimates of these risks, and then we can start to risk stratify patients. So what this figure shows is how we can risk stratify patients for both their risk of cardiovascular events or death versus their risk of end-stage kidney disease. So on the y-axis, if you move higher, we have patients with increasing risk of death or recurrent myocardial infarction, and on the x-axis, we have patients with increasing risk of end-stage kidney disease. And every point on this figure actually represents the risk of a patient in terms of both of these outcomes. So you can see that there's a huge variety actually of risks across. This is all patients with chronic kidney disease here that we've identified. But not, as we know, there's a large proportion of these patients actually who have very low risks of end-stage renal disease, but have high risk of cardiovascular events. There's a smaller group of patients who has a high risk of end-stage kidney disease, but low risk of cardiovascular events or death. So we can start to, put people into quadrants of risk that actually look very different. And you can start to imagine how our approaches might be more individualized based on where these individual risk distributions of a patient actually sit. What we've been going on to do then is we can actually take these absolute individualized risk predictions and then apply treatment effects from the published randomized controlled trials and meta-analysis. And we can even take that a step further, where we can actually use information from the discrete choice experiment to weight the different outcomes differently, recognizing that end-stage kidney disease event actually doesn't have the same weight to patients as dying. So we use this to conduct what's called a net effect analysis, where we can synthesize a patient's individual risks, the treatment effects, and their weighting on these effects to actually categorize patients as being likely to benefit, have equipoise or harm from an invasive approach in both the ACS and stable angina scenarios. So this is a figure that starts to try to do this. What's on the y-axis here is the reduction as you move down in the number of deaths and MIs in an ACS scenario with invasive management. And as you move to the right is actually the increase in risk of end-stage kidney disease events with invasive management. So that, again, the points are an individual patient, and the colors actually represent the kind of grouping patients into those where there is a net benefit, or the reductions in the cardiovascular risks exceed the weighted increases in end-stage kidney disease events. The blue is where there's equipoise or equivalence, and the red actually represents patients actually who have the potential for more harm. So an increase in the weighted risk of end-stage kidney disease increasing above the potential benefit in reducing cardiovascular events. Just in the interest of time, I'm going to move to this, which is really our current work now is validating these models, which are really pleased to be working with Peter Burks and Adira and their teams in BC to validate these approaches in BC cohort, and also placing this actually into the hands of decision makers and the patients themselves and physicians is really our next goal. So we've been working on a decision aid through the CanSolve network to actually do this, that actually addresses both ACS scenarios and stable coronary artery disease scenarios to give patients personalized estimates of their risk. So we use some principles of decision aids and risk communication to try to show absolute risks and communicate this visually, present it to patients and healthcare providers, and also allow patients to rank their priorities and express their preferences for treatment, which we hope will improve the decision-making experience, get all of this information on benefits and trade-offs into the decision-making process for patients. So I'm going to conclude here so we have a little bit of time for questions, and just to highlight that I've tried to touch on how chronic kidney disease is associated with a high burden of cardiovascular disease and has some unique presentations and risks that I think are worth being aware of. We have more effective medical therapies than ever to prevent cardiovascular events in people with chronic kidney disease. So it's exciting to see that and to be in that time. And then finally, the benefits and risks of the invasive treatment approaches to cardiovascular disease actually do vary quite a bit across the stages of chronic kidney disease and by patient characteristics and presentation of patients as well with acute or stable diseases. And I think this requires us to take a personalized shared decision-making approach, which we're trying to do in the work I've touched on today. So I'd just like to acknowledge a lot of our members of the team in Alberta that we've been working on some of these projects with, and the support from the CanSolve CKD network for this work in particular. And we'll stop here and happy to discuss and take any questions. Thank you very much.
Thanks, Matt. And if you stop sharing, then people.
Oh yeah, thanks.
That'll make it easier.
Yeah.
So thanks for that there. I think it's an outstanding overview and reminds us of things I think that we say we know about cardiovascular disease and kidney disease, but we don't really know how best to take care of our patients and how to, the shared decision making, I think, is quite exciting. Are there questions or comments from the audience? Feel free to put it in the chat or the Q&A. I know we're running a little bit out of time, but maybe just while I'm waiting for someone else, the shared decision-making tool with the happy face, to just talk about how some of the patients are finding that, or what's your initial feedback on those tools in terms of visualizing risk as opposed to hearing about it.
It's been very interesting. So we have been working through a process of human-centered design that involves stakeholders, including patients and physicians, in co-designing this tool and evaluating it and iterating it as we go. We followed international patient decision aid standards, where some principles that are very important are presenting absolute risks, making comparisons clear, and I think showing different ways to visualize risk. Not everybody understands just what presenting 17% versus 24% means, and even I think when you actually see that, it can be very helpful, and you visualize it versus just presenting numbers. So this has been very interesting. I think, the feedback we've seen is that, some patients find the visualizations very helpful. Many physicians as well really find the visualizations very helpful for communication. Then there are some patients who certainly understand the percentages and don't like it. But I think having multiple strategies to communicate risk is really important, because that's a big challenge in this, is how to communicate this. And I think when I don't have a tool, I'm very challenged and I start to simplify very quickly. So hopefully.
Yeah, no, it's a great point. I think there's probably some additional work that people can do in terms of cross-cultural acceptance of different things. There are a couple of questions in the chat. So how do you integrate GLP-1 agonists in medical management for obese and or diabetic patients?
Yeah, that's a great question. I didn't talk about GLP-1 agonists, but there is a wealth of information evolving and it's come out on the cardiovascular effects of those therapies as well. So I think there are some nice elements in when you look at that systematic review that I highlighted from the BMJ, where there are some medications have side effects or different effects that might be preferable in a given patient, one patient than another. So I think those might be kind of some of the again, like shared decision making kind of approaches where you can speak about, well, what are the experiences of being on a GLP-1 agonist? How do you feel about an injectable medication or a once weekly medication? How do you, is this someone who already has a lot of difficulty with gastroparesis where nausea and early satiety might be very hard to manage? So maybe we can individualize the choice to some degree, particularly with those agents versus SGLT2 inhibitors and how we choose them. But that's a great question to consider.
Right. And then there was one last question about whether, again, congratulations on the tools. And I think we're kind of anxious to see if we can get them into practice after you've finished smoothing out the kinks. There was a question about whether or not in Alberta you guys are using the Flozins for non-diabetic CKD risk reduction.
Yeah, we've had some discussion amongst our colleagues. I think many are now, particularly after the DAPA CKD trial and the analysis in IgA nephropathy has given many, I think, of us more confidence in using them in that population. It's still less evidence, and I think still a challenge of knowing like how low of an EGFR can you
and
go.
EMPA-KIDNEY is also addressing that non-proteinuric and proteinuric disease, and so we're not there yet, but I think DAPA gave us a little bit more confidence in proteinuric lower kidney function. I think it's still up in the air a little bit. Anyways, we are at the bottom of the hour, and I want to be respectful of everyone's time, including yours, because it's an hour later for you in Calgary. So, but thank you very much for a really terrific, inspiring review of both cardiovascular disease and kidney disease and the complex interaction of the two, but more importantly, how we can take that population data and now synthesize it down and use tools that you and your team are developing to really help us have individualized decision making based on facts, not on thoughts and fears, because I think that that's how we've been talking to patients for a long time. So it's really fantastic to see the work coming together. Thanks a lot, Matt.
Great. Thanks so much for having me.
Thank you. Bye. Thanks, everybody.
Bye now.